Very much, and thanks to the organizers to invite me to hold a talk about a topic I've never talked on so far. So it was very interesting to go into the scarce literature on that, and you already addressed these. I have no conflicts of interest. That in breast tumor recurrences following breast conservative therapy decreased steadily over time. This was already addressed by Roberto Arecchia, and although we believe that age might be a surrogate for something different, age is believed as one of the strongest risk factors, and the lowest published annual in-breast recurrence rates from randomized prospective trials up to now are somewhat around these dimensions. So over 50, it's 0.4% from the START-B trial was the best or the lowest evidence I found, and at lower ages it's somewhat around 0.7% per year. But in newer series, there is a further decisive reduction possible to 0.4% or lower annual recurrence rates also, and especially for young patients, by local dose augmentation to the tumor bed. For example, our own IRT boost pooled analysis within Europe, where we landed up at 0.2% also for young patients, and also the young boost trials, but these are still in progress in publication. But whenever it occurs, you already mentioned that it is a catastrophe for the patient who is confronted with salvage mastectomy, which is the accepted standard for this situation, with local control rates yielding around 90% subsequently. However, detection of these recurrences frequently occur at early stages due to the close follow-up schemes, which are in principle amenable to a second breast conservation approach. But a breast-conserving surgery alone is associated with high local failure rates up to 50%, and therefore additional re-irradiation has been promoted as an attempt to prevent these subsequent relapses, mostly performed by partial breast re-irradiation or PBrl. What do we know about the normal tissue tolerance of the female breast? Not much. If you look at the date 1989, there has been hardly ever additional knowledge since then. But what you see from these curves, is there a stick? No. What you see from these curves is that the smaller the volume, the higher the tolerance to irradiation. This is a principle which is true for almost every tissue. But is it really possible to retreat a breast with 2 times 50 to 60 gray, even to a small volume like a tumor bed? Because this graph would predict very high complication rates if you do that when you end up at 110 or even 120 gray equivalent. So we performed a survey of the literature from the last 10 years, and we identified 10 publications plus some abstracts and papers in press. And accounting for overlapping cohorts in these publications, we identified 310 different patients. Maybe there are some more, but I think this comprises more than 90% which have been reported on in the last 10 years. And all of them treated by PBrl, very different methods, brachytherapy at various dose rates, KV-IRT, external beam radiotherapy or combinations. And we tried to do a dose volume analysis and dose equalization of these different methods, and finally, an analysis for tumor-related outcome and late effects with regard to method and dose if possible. So these are roughly the techniques: interstitial, endocavitary, KV-IRT, IRT, and an example for a modern 3D IMRT. And what is the philosophy of a target volume of partial breast re-irradiation? Well, it is triggered by the dimension of the surgical resection clearness. And if you then try to cover a target volume of up to 3 centimeters of all directions, calculated from the former macroscopic tumor edge, you will encompass most of the cells which could be remnant according to the Holland model. And we did a dosimetric comparison of the IRT techniques of these various methods just mentioned before, and you don't need to be a radiation oncologist to realize that there are tremendous differences in the ability of covering this target volume if you want to treat that classical target volume. But there are some common characteristics of these re-RT trials, small single cohorts due to the nature of the disease. In the mean, 31 patients per cohort, only impressed tumor recurrences, so no other lesions, In the majority, true local recurrences in the former index quadrant, small tumor sizes up to small T2. Breast-conserving surgery was possible with free margins, and all of these, or the majority of these, had received a classical prior adjuvant radiotherapy during the primary course of treatment, mostly 50 gray whole breast irradiation plus a boost up to a equivalent dose of 65 gray, dependent on the method, whether brachytherapy boost or something different. And in almost all of these patients, there was a remarkably late onset after the primary treatment. The mean of means was 70 months, and the minimum time span to the retreatment was 12 months. The highest evidence by far is for brachytherapy, with roughly 80% of all patients treated by some type of brachytherapy. And in these 254 patients treated with that, there were 3 prospective series with 71 patients included. And the treatment dose ranges, you can see that with the various dose rates, something between 30 and 50 gray. A very interesting attempt is a Heterogeneity pooled analysis, which has been reported at the San Antonio Breast Cancer Meeting. Pooled analysis of 217 patients in 8 European institutions. Surprisingly, the experience, or the published experience on retreatment by external beam radiotherapy is hardly existing. There's only one series from Pittsburgh, Deutsch, which was an update from Mullen 2002, 39 patients treated with electrons 25 times 2 gray, but there is an ongoing, or presumably closed phase 2 trial from the RTOG 2014 with 61 patients with 3D CRT, a hyperfractionated accelerated schedule, twice daily, 1.5 gray up to 45 gray, and very interesting, a highly standardized reporting of treatment volume, very good QA program with primary endpoints toxicity and comparison to the RTOG 319, which is a primary APPI trial. Secondary endpoints, local control, freedom from mastectomy rates, overall survival, and a subset correlation of circulating tumor cells to further outcome. Intraoperative radiotherapy for PBrl, even scarcer. There is a small trial for KV-IRT from Mannheim in 2007 published, 13 patients for an in-breast tumor recurrence with single surface doses between 15 and 20 gray. And this is a personal communication from my friend Roberto. Thank you for that. There is a Milano series of 82 cases with single shot electrons 14 to 21 gray. I will go in detail on these data later on. So what about dose comparison of all these treatments? Physical doses of 30 to 50 gray are not the same as you have heard from the previous talks. We need the linear quadratic model and the alpha beta values. I was a little bit more conservative in estimating the effects on tumor. This is not so clear up to now. I chose 4 for the tumor effects and the late reacting tissues, which are dominant for the expression of late sequelae, is around 3. We tried to account for fractionation and dose rates. We assumed T-half repair times of 1.5 hours and tried an equalization to 2 gray single dose equivalents, or EQD2. So this is the table of all the trials. There you see the references, the physical doses with a very large dose range fractionation techniques. And if you equalize it now for the tumor effects with the EQD2 for alpha beta 4, you see a very wide range between 30 and 60 gray effective dose. And the same is true for the late tissue reaction. Again, this wide range, what has happened between 30 and 60 gray dose equivalent, or even more, 66 and 67 gray. Below, the KV-IRT, as you have seen before, is only valid for a very small rim of up to 10 cube centimeter, which is not really applicable in that setting or comparable. What about the comparison of treated volumes, which is the second important issue, not only the absolute dose or the corrected dose? Many of them didn't state the volume they treated, and if they stated it, it was roughly the same. Mostly, again, in brachytherapy, V100, this is the volume which is covered by the 100% isodose, which was reported around 100 cube centimeter, and the PTV sizes in the range of 60 to 70 cube centimeters. So now some data on outcome. Tumor-related outcome, the follow-up after in-breast tumor recurrence was 50 months. Again, mean of means with a range of 21 to 89 months. All authors provided data on local tumor control, mainly by Kaplan-Meier estimations in the range between 2 and 10 years. And for all 310 patients, the cumulative in-breast tumor control rate amounted 87.3%. Again, if you go into the details, and here you see the various studies and the tumor-related results, some of the data and the follow-ups already very mature, you end up at high local control rates, especially, and I have highlighted all these data, where we have some reliable information on actual doses to a given volume. And if you concentrate on these, you end up at local control rates of 90% and above. And if you look at this was an investigation where the authors stratified their analysis lower versus higher doses and lower versus higher implanted volumes, and they could show that the lower the dose and the lower the implanted volume, the worse is the outcome. And this contributed to the local control rate of altogether 77%. But a nice proof of principle. Any more information on local control? Yes. Again, grace to Roberto Arecchia, I can show you these slides. I think even with his own linear accelerator on the right side. The EIO series on IO-ERT in Milano, 82 cases with 14 to 21 gray after re-quadrantectomy. A long median time interval between initial and retreatment of 10 years. A median follow-up after retreatment of 53 months, so also quite mature. And 5-year local control rates of 85.5%, disease-free survival 80%, and overall survival 100%. And an additional information comes again from the Sheck-Estro pooled analysis, which is presently only available as abstract, but one of the co-authors, Alexandra Resch, provided me with some data. Grace to her, I can show you these informations. The 5 and 10-year actuarial rates for second local recurrences were 5.6 and 7.2%, yielding local control rates of 94 and 92% respectively after 5 and 10 years, actuarially. Distant metastatic recurrence rates at 5 and 10 years between 10 and 20%, disease-free survival and overall survival rates are mentioned here. These results were interpreted by the authors to be at least equivalent to salvage mastectomy series. And grace to Alexandra Resch, I can show you this very nice picture about the topography of the sites of the first and second recurrences. And just focus on the very left side. There you see that 2/3 of all patients have all incidences in the initial tumor sites. So this is a very nice graph you gave me. And she also provided me with that multivariate analysis of prognostic factors of second local recurrences, and in the multivariate analysis, only high grade was associated to be a predictive factor for the development of an eventual second local recurrence. For distant metastasis, not surprisingly, it was tumor size primarily, and for overall survival, it was high grade again. Now, something more difficult. What about late tissue reactions? Although all authors provided data on these reactions and/or cosmetic appearance, it's somewhat more arbitrary. All reported about very low acute toxicities in all methods, and the most frequent late reaction, also not surprisingly, was fibrosis, but hardly performed along standardized scorings, but if performed, e.g. along lensoma, grade 1 up to 2 sequelae in terms of fibrosis, telangiectasia, and/or pain ranged somewhat between 40 and 80%, with rare grade 3 and grade 4 events like skin necrosis or ulceration. In the Sheck-Estro series again, 141 out of 217 patients developed altogether 193 complications, mainly fibrosis. 11 of them graded as 3 or 4. And even more arbitrary, what is cosmesis after this retreatment? Of course, it is highly influenced also by the grade of fibrosis, and it was hardly ever standardizedly reported. The most frequent scoring of overall cosmetic results in the various forms of scoring that was up to 30% is excellent, up to 50% is good, and up to a quarter to be poor. Not surprisingly, in the electron series with fractionated 2 grade times 25, which I would regard to be an obsolete approach, 2/3 of the patients showed marked or obvious skin pigmentation changes in telangiectasia. So I try some conclusions. Up to now, we have no clear dose-volume relationships identified for tumor effects and late tissue reactions. The heterogeneity of doses, volumes, and methods, and hence dose distributions, are much too high within these small series. However, and unlike the initial graph I showed you, it seems feasible to reapply doses of 50 gray EQD2 to a partial breast volume of 80 to 100 cube centimeter with brachytherapy, IOT, or external beam radiotherapy. Lower volumes and/or doses seem to be associated with inferior local control. Fibrosis is the most relevant late reaction, mainly G1, G2, and the cosmetic results seem to be satisfactory. Better dose homogeneity, especially by methods like external beam radiotherapy or intraoperative with electrons, should be investigated for influence on late tissue tolerance. So PBRl is an alternative to mastectomy in a highly selected group who show up with in-breast tumor recurrences of small size, preferably with a long delay from the initial event, so far over 12 months, where RO resection is performable, and it yields high breast preservation rates of over 90% in 5 years without compromising oncologic safety. And there's best evidence for brachytherapy. There's still little information about the effectiveness of PBRl via modern strategies, like intensity-modulated treatments, intraop, hypothermia, surprisingly, which is addressed always in macroscopic recurrent disease, not in this setting. And all these should preferably be investigated within trials with a strong emphasis on quality assurance, precise dose volume definitions, standardized scoring, and thus optimizing of target covering and long-term cosmetic assessment. Thank you for your attention.